And then she's also, Sineva's going to pull up some pre-polling questions. So I ask everybody just to take a quick second and read through those polling questions and put your answers in there.
Okay, you can see the, okay, yeah, poll on your screen.
Yep, I can see them. Question 1 is, did your hospital establish an incident command? It's multiple choice. And what percentage of pre-COVID volume are you currently at? And she'll give you.
We'll give it a few more seconds, 20 more seconds, and then I'll show the results to everyone. Alrighty, I'm gonna show the results. You see those on your screen?
Yep.
Okay. Did your hospital establish an incident command? 76% said yes, 24% no. And what percentage of pre-COVID OP volume are you currently at? 6% said 90%, 35% said 75 to 90, and 59% said below 75. Alrighty.
Great. Thank you, Sineva.
Yep.
Now we'll turn things over to Eric Rogers at BKD to get us started.
Hey, thanks, Kate. Glad to be back again this Friday with everyone with another series, 3 of 5, and going to focus more today on operations. And we have 2 wonderful presenters today that'll be joining me. The first is Kevin Rash, and Kevin, you may want to get with Sineva after this. I know you're a fellow in ACHE and have been very involved with the organization for many, many years. So Kevin, just kind of Wade's background, Kevin's been on the provider side for over 25 years in healthcare. He's a clinician. He's a physical therapist that started off treating patients and then managing a group of therapists and then managing a physician clinic. And one thing led to another, and he wound up as the an executive vice president level within a very large health system here in the Midwest. And so Kevin's been with BKD for several years, really focusing on operations and helping organizations kind of where they're at, make improvements, and certainly in the COVID, make some adjustments to what the new normal is for their organization. So Kevin's a director out of our Springfield, Missouri office and is a good friend and sits right here by me in the office. So thanks for joining, Kevin. And we've also got Miss Jamie Pham on the line. Jamie's from the South, was in Texas for quite a while and then got her master's at UAB down in Birmingham and has been with BKD doing consulting work for quite a while now and helping Kevin on a lot of the operations issues. So the 2 of them are wanting to share some of the feedback that they've had in working with hospitals, specifically in COVID, to reset. And again, we really want to encourage everybody that's on the call today to comment. We'll ask you some questions about how things are going at your hospital, what's working, what's not. We want to share ideas and thoughts as we move into this. But anyway, I'm going to go ahead and turn it over to Kevin and let him and Jamie kind of get started on their slides. And these are the topics for today. Reopening and realigning your different service lines, monitoring your labor and your productivity in your organization. So, you know, based off of the poll results, 60% of you are still below 75%. And if I had to guess, I think that it is going to be a much slower recovery than all of us anticipated even 2 or 3 months ago. So it's great that we've all got a lot of funds that have come in from the federal government. We've talked about those the last 2 weeks, but how do we use those funds appropriately? How do we bring staff back on? How do we take care of volumes whenever they do come back in? And then I'll kind of round out at the end, talking a little bit about the interim final rule waivers and how some of those may apply to your organization. And then if you're in an ACO or other quality programs, what kind of flexibilities came along with those. So, all right, I'll turn it over to Kevin and Jamie to get us started on reopening the hospital service lines.
Thanks, Eric, and I'll take it from here. And you know, part of the ACHE is, as an adult learner, we continue to learn, and you know, we all know that over the past 5 or 6 months, we've been challenged with probably something that we never thought we would, especially in healthcare, and then you know, really kind of something that affected not only us as a country, but really the entire world. So we move on to kind of the, am I in control of the slides, by the way, or is somebody else?
Nope, I am. You can just tell me when to move forward with next.
Move forward. Yep, we're ready to go to, you didn't let them see our pictures very long. That's awesome. Very good. But that adult learner part of ACHE is something that, you know, to keep in mind, and happy to be involved with, you know, the continuing education of everything that's going on, and just excited to be here with you today. So what you kind of, you know, when we're reopening or considering that reopening, you know, our service lines continue to be challenged. And, you know, with that consideration, you know, what do we want to do? Do we want to continue with them? Do we want to launch new ones, or do we need to even be ceasing some? And so here, what you see in this hospital operation response to the COVID pandemic, you know, here we see how we might categorize kind of the timeline that you may have seen out there in other, you know, presentations, other web sharing, you know, anything that you might be reading. And I thought it'd be good just to kind of start here briefly in these 4 areas. The way I kind of categorize this, you'll see it there in that timeline, is that red area there that is the response. And then do we survive or recover? Do we recast? And then do we transform? So specifically in that response area, you know, you're really into crisis management. It was interesting to see that, I wrote it down, that almost 25% of you responded and saying that no, didn't set up an incident command. And that would be something that might be of interest in the future. There's a lot of literature out there on there, whether it had been, you know, an individual event as a, you know, down in the South and around the Gulf, you get into a lot of response around hurricanes, and some of those are going to be coming through here more in the Midwest. We had tornadoes, and I've had I guess you call it the opportunity, if you hadn't heard of the Joplin tornado back in the early 2010, or excuse me, 11, actually was involved with setting up a incident command revolving around that, where there were 163 deaths, you know, very quickly, and a complete hospital decimated from that. So just interesting things around setting up your incident command. The one piece I'd say in your response that's very important for you to be doing, and it's document, and that's that incident action plan that you see listed there. Very important to have that. You're going to need that to really get back into understanding why we made decisions when we did, and it's okay to change it. This pandemic is creating different events for us each and every day, with increase or decline in certain areas, and you need to be kind of thinking through that. But that would be an area that in that response, you're in that crisis management. Then you move into kind of, can I survive this? Can I recover? And not only are you looking at that incident action plan, but now you're really starting to think, how do I get a team around planning to demobilize everything that I've put up? So if you put up tents to do specialized testing or to screen, are you demobilizing out of those areas, and really documenting that? And not only is it documenting, but what did you spend on it? Because some of these funds that you're getting, experience from being involved in the tornado, it took 18 months post-event to really kind of work through everything that came through financially from the states and federal governments in that piece. So really want to be documenting why you made that decision, what it cost you, and kind of look through it. I'm going to stay in this endure crisis mode for a moment. You know, you're really looking at what are the community health needs. You're considering different delivery methods like telehealth. You've got, you know, significant regulation changes in the form of waivers. And then really, as Eric pointed out earlier, you know, what have you been doing around the CARES Act, your decline of revenue, what are you documenting in that? And I put the hospital health needs in there. You're really not thinking of your hospital health needs, and this will shift when you get into that recast and transformation, because right now you're really still focusing on, kind of what is the community health needs at that point. Then you get into that recast. The incident action plan is still green. Your demobilization plan is part of that incident action plan now. And then, I put in the PDSA, and that's, Plan, Do, Study, Act. And I used this a little bit differently when I was in an executive role. This was kind of, please do something already. You've been sitting around trying to figure out, your community needs you to do something new. And so please do something already plan is something to be placing in there. And then you start to think, what can I open, what can I not? And the CDC and the community health departments, that's those initials there, are really kind of to help you there. You'll see now that the hospital health needs kind of move up, and the community health needs, it's not that they move down, but I would have you really start to think about, what is the hospital health? Emotionally, what's your team going through? Physically, are you exhausted because you've been hit hard with the pandemic? What's going on medically with your teams? But you really now, okay, what's the financial components going on? You're getting these one-time influx of revenue or dollars to help you, which is great. But you really need to be thinking, okay, how am I going to recast? And then you get into the transformation, right? Where are we going? So if we can move on to the next slide, the question that I ask you is, where do you, and this could be anybody chatting in if you want real quick, or, turn on the mic interaction. My question is, where are you today, right? And so you see the blast on there that shows in between survive and recovery, recast. Anybody willing to say where I'm standing today within my hospital? I'm looking for the chat box too. Or mic it up. Okay, I'll take that as a survey as I don't know. And the reason I would say that is the challenge that you have with this is you might have gotten yourself past that survival mode and you're ready to recast. And what's happening now across the country? We're seeing some resurgence or increase in number of positive tests. Some regions are having that increase of the acuity of the inpatient hospital stays, and just really maximizing their ICUs. In the smaller rural areas, your activity may be a little bit different. I grew up in Nebraska, and my brother tells me he's been practicing social distancing ever since he was born. It's just a lot of land, not going on too much there. So, where are you in this piece? And so when you figure out where you think you are, I would say most locations at one point over the past month or two felt that they were past the survival and they were ready to recast. And then you start to think about, okay, what are the things I need to be looking at? And when I brought this slide up, it's revenue optimization, cost management, and then what are the markets and the opportunities? We've already talked a little bit about that revenue optimization. And the challenge I would ask you is, in that incident action plan and your demobilization plan that you're documenting, are you putting in those decisions? So when the CARES Act funding and some of you may be had the opportunity to use PPP, how are you going through all that piece? We're not here today to talk through that, but from an operational standpoint, my mind is around my team to say, okay, is my finance team helping me document the decisions we're making clinically and operationally? And are we getting that down? So in 3 months, I will have slept 90 nights. I forget about half of everything I did that day each night. So 90 days from now, I haven't forgotten everything, but I need to be able to look at something to revisit what we did in our decisions.
So Kevin, you may kind of touch on this a little bit later, but you know, as I think about particularly our smaller hospitals beginning to recast and transform their organizations, are you seeing some of the small hospitals use this opportunity with COVID to exit some service lines that they may have been in historically, and the volumes had kind of were low to start with anyway, like in orthopedics, for example, where they were always low. And if we looked at it from a service line level, we were losing quite a bit of money. We were paying our doctor quite a bit, and we just didn't have the revenue. And we think that this is the time to exit that service line and really focus on more med-surg business. What are you hearing out in the market in terms of mid-sized and the smaller hospitals being a little bit more forward in their recast of their organization?
Good question, Eric. And I can actually give you a live example of a small rural hospital in Iowa. During this, we went through and did some service line assessment with them and really looked at 3 surgical areas. So their OB and GYN services, their orthopedic services, and their general surgery. And really, as they were having a struggle prior to this, this really helped them push themselves over the top to say, should I stay in the orthopedics? And fundamentally, they've gotten with their board and they're moving away from doing orthopedics on a regular basis and really trying to up that with their family practice, and then they would refer that out. It's just too costly for them. They've downsized their general surgery. They're looking to downsize that, but they're really working through the extension of that service line because the emergency department sure needs that. And then interesting enough, in that particular market, the OB/GYN services, they're going to shift the way they're doing that staffing, to your question, Eric, and really look at extending from their family practice that also have OB certifications to, assisting with the APNs and even midwives. And they have a larger Latino population in that area too. And so they're really looking at bilingual providers to see if they can land that to help them with that piece. So it's really an opportunity to shift that. And we'll talk a little bit further more here in the next couple of slides about that, but it's a great question, Eric. And that kind of speaks to kind of that markets and opportunity, what was happening before, really now will that shift. And the other part of that would be telehealth. I would tell you, if you're looking at the shifting markets and you're not in any form of telehealth, I think the consumers are gonna find a way to bypass your organization at that point in time, if you're not somewhat in that virtual space. This is a question, I wish we kind of had it out there on this particular slide that we're looking at here. The question I have is, anyone have a thought of a new role that's come forth based on this pandemic that they're needing to kind of staff differently or get provided within their organization? Screeners, okay. Do you think the screeners will continue, or will you find a way to do that as they're coming in? I don't disagree with you at all. I mean, definitely screeners, right?
Yeah.
You've probably limited your entries.
Who are most people using, repurposing to be screeners in your organization? Is it receptionists? Is it nurses? Who are folks using?
So Eric, I've seen, this is Kevin, you continue to jump in. Clerical workers. I've seen nurses, I've seen lab techs, I've seen administrators. It was during that crisis mode, it was a matter of, repurposing and going out there. I think as they transform, they really need to think through what is the job requirement and the skill level that they need. Yeah, registration, EMS employees.
Kevin, who are you seeing as kind of the person that's the liaison with the local health officials to report or do tracing of positives and different things like that? Is that chief nursing officer? Is it their quality? Who are you seeing fill most of those roles? Or if you want to comment on who's doing it at your organization, drop that in the chat box.
So what I've seen, Eric, is similar to kind of the responses we're getting. It varies, and usually it's coming from the executive roles to keep that that communication going. So the right information is coming from the teams to incident command, and whoever the incident commander, and it doesn't have to be you know, might be the chief executive officer, the chief operating officer. But they may have somebody that's in their communications department or marketing department areas that is that liaison that continue to keep that connection with the local community information, whether it be the newspaper, those areas, or even just doing their own weekly update. If they're in a small enough community, the radios, I've seen radios come in and do a virtual talk with those local hospital leaders to assist in getting that communication out.
Kevin, I have one other comment that I wanted to make, and I see Kim Jacoby there at Marshall Browning's on the line. Hi, Kim. One of the things that I was curious of in terms of operations is when you've got a patient that comes into the emergency department that is symptomatic and tests positive, do you feel like the organization has a good process in place as to where do we put them? Do we have our dedicated wing? Does it have negative pressure? So I'm kind of curious to hear, Kim, if she's on audio as well, kind of your process and comfort level for how do we respond quickly when we have folks come through the ED?
Well, we usually request them to call us in advance. As they're coming up into the parking lot, we ask them to call the emergency department. We don't bring them through the front lobby. We meet them. We don on our PPE or full gear, and then we meet them outside with a mask as well, and then we bring them in through a side door. As long as we have one of our exam rooms is what we like to use, because we have two exam rooms. The exam room is a single occupancy room, and then our other two rooms are double occupancy rooms. So we try to keep the ones that are having or demonstrating symptoms into one of those two single rooms.
Thank you. Sorry to kind of put you on the spot there, Kim.
That's okay, Eric.
As a follow-up to that, how is your nursing staff doing? Whenever they know that they're caring for a COVID positive patient, what are you doing kind of internally to help assist, emotionally, but also just tactically from the cleanliness standpoint to help that nursing staff and others that are in contact with those patients?
The nursing staff, since we began this, I was a little leery because I had the little skittish ones. But actually the whole team have stepped up. They do a fantastic job. Nothing really, it doesn't scare them like I thought it would be, because we do have a few little skittish ones, like I said, but they've all just stepped up. They get it. They're right on the ball. They know what they're supposed to be doing, and they feel comfortable about it. They kind of joke around with me because the ones that we have tested, if it's positive or negative, and they know if they've been exposed or not. And they said they can always tell, because if it's negative, I text them, and if it's positive, they get a phone call. And I've had to make a couple of phone calls to the staff since all of this has started, and they've done it. They've been exceptionally well at receiving the information. They know what they need to do. I'm proud of them. They're pretty good rock stars.
Thank you. Kevin, I'm going to go ahead and turn it back, but I'm seeing the comment come in from Sharkey down there too. It looks like, they've had a pretty big spike here recently, and it's starting to spread through their staff. So as you and Jamie you know, get a little bit further here, I think you're going to talk about staffing as well. And then how do we adjust when all of our staff start to get sick? So.
Yeah, thanks, Eric. So in that cost management on this particular slide, right, two things, actually three, they're all important, but I just touch on really the management structure. It's an opportunity to kind of look at this. You might have some realignment that you need to do, but really then into that next box, that departmental staffing, we're going to show some examples of kind of what is baseline, what is, you know, pre-COVID, after baseline, and then what effect did COVID have on kind of the staffing and realization that was kind of going on there. The last comment I'd make really kind of in this cost management is around supply chain. And if hopefully you didn't have to learn a bunch, but I'm going to guess almost everybody learned something new in supply chain. And when I asked the question around what roles do you kind of see coming from the past 4 or 5 months, what we're really starting to see is really folks that are taking supply chain kind of to that next level of engagement through their clinical staff to make sure that they don't get caught with not having the right supplies and they have the right you know, right areas stocked, but also, you know, what is the right level to have if we were to have another, you know, surge to where we needed the PPE. And so that supply chain leader, not only a clinical standpoint, but really what is that business optimization and acumen that person needs. So we're seeing kind of a resurgence around supply chain leadership. We can move on to kind of to the next one. So we're really then starting to say, okay, how do I start to make a management leadership decision and what are the guidelines that may help me and where do I get those resources if they're not coming through? And so what you're seeing here is really the change in positives for reported cases. So in May, the dark purple is where I'll kind of have you focus, right? Those were the states that were reporting, you know, 40,000 or more positive tests. Some of that's just based on the overall population of those states. They're larger states, they're more populated. But July, if you look at kind of the darkest blue, those are all the states that when we pulled this data off the CDC website that are now having more than 40,000 positive tests. And, you know, why is that? We've got more access to testing. Right, more people are getting testing. We're getting more positives. I believe that as an American or as a citizen, we're starting to move about a little bit more. We're a little freer with our movements. We feel safer. If you're kind of like my wife Ginger, it's I got to get out of the house. I've been in here for 5 months and I need a little bit of change. And then just kind of that basic freedoms. So watching the website for the positives and then trying to affect that acuity. But then when you move on to the next slide, there's really kind of 5 areas that I would really have you think about. The CDC is giving us guidelines, and the guidelines in the presentation that we have a click on box there at the bottom that you can kind of get to and look at those guidelines. I'm pretty sure everybody, if you don't know how, that's there for you, but most of you probably have been able to get there. But when you read the CDC guidelines, they're pretty broad, right, and pretty general. And they then point to kind of saying, let's give some of that from a federal standpoint. We're giving you these guidelines, but each state's a little bit different. So the governors have their teams, and usually it's a infection prevention physician or a group collaborating with the governor, but still the governors in the states are giving you broad guidelines, and they point to either the county or the city. So your county health department officials are really trying to help you through that. I know in our county where I live, our health director has done what I would say is an A+ job in making sure he's communicating out to everybody and doing everything that we can have and safe. So just yesterday, to give you for example, we had our 12th death related to COVID. And every one of them, when he reports it out, it's a devastating day for him. He takes it very, very seriously and has been trying to keep everybody safe. But he's also the county, so then he's got to get into the city to where you've got the mayors that might be changing those up, or those county commissioners that are assisting with you. So as a healthcare organization, I would have you point yourselves to the kind of the health organizations that have given some guidelines. And we're going to walk through a joint statement here next and kind of talk you through some potential opportunities that may help you with that in your decision making of what to reopen and how to reopen, knowing that those would be gradual reopens. So I find that this is probably the most helpful for hospital and healthcare facilities in some of their decision making, since it's coming from those that are doing that. And so I'll turn the conversation now over to Jamie and let her walk us through that. And I'll be back with you shortly.
Thanks, Kevin. So this is a joint statement from the American College of Surgeons, American Society of Anesthesiologists, the Association of Perioperative Registered Nurses, and the American Hospital Association. So this provides further guidance and considerations to guide our physicians, nurses, and local facilities in their resumption of care in the OR and all procedural areas. So this presentation right here, it shows the summation checklist that we have put together to help our clients. It's based on the joint statement. So if you wanted more information about this, there is the detailed guide that's located in our COVID-19 response page. Next slide, please. This is one of the topics that we would want to focus on. And one of the areas that we have seen our clients focus on is the COVID-19 testing within the facility. Most, if not all, facilities have established a process flow to screen patients, visitors, and any incoming personnel at all entryways, or have decreased to a more central entry area. This helps decrease overuse of staff, like the screeners we mentioned before, for temperature checks and individual screening. Facilities have also implemented off-site COVID testing via drive-through to help decrease risk for hospital staff and patients if a patient felt that they have been exposed to the virus. And furthermore, some facilities have implemented telehealth resources to decrease the risk of spread by limiting patients' needs to be physically present for clinic visits. And we have also seen a lot of clients, due to the resources both with the patient and the facilities, some of the telehealth is conducted via phone rather than phone and video. Additionally, there has been more guidelines to follow, such as social distancing, masking, and other safety policies that individual hospitals and clinic facilities have put into place to keep their staff and patients safe.
Jamie, before we move on, I just wanted to make a good question and then maybe a comment. I'm curious to know, did everybody kind of go to a tent process to get it outside their hospital when they were doing this initial kind of crisis management? Or what strategies did you use to, limit the incoming and to be able to do some screening and then get to the second question will be, how many of you are able to get to kind of that quick COVID test, or is that still in process? Anybody willing to tell if they did a tent process?
This is Carrie from Sharkey. Our state actually is, like, as of right now outside, we have a free COVID testing site open right now in front of the hospital. The National Guard, Armory, and UMMC in the state send their people out to different locations. So they're actually out there doing it now. This is the second time that they've come to Sharkey County. We do test our patients. Pretty much, if you come in the emergency room and you have a sniffle, you're pretty much going to get tested. Now, what we're doing, because we're not able to do the rapid tests here, we have someone drive it 45 minutes away to another facility, and they rapid test it for us and then send us the results.
What's the frequency you're having to take tests up? Are you logistically going up once a day, or as it's necessary?
As necessary.
Okay. Okay. So I want to thank you for sharing that. So here's one of the most interesting setups that I've seen. So in a smaller kind of community in Missouri, they set up tents to begin with, but as the summer started to come along, they were trying to figure out how they could get their employees into a more comfortable, environment, and also for the patients, because the heat, humidity, thunderstorms that would roll through. So real close to their campus, there was an old bank, and they're now using the city and that bank. It was not being used for anything else. So they're actually using the drive-through portion of that bank for people to drive up and tell them what they need, and then they walk out and do some further registration and testing, and then bring them in. But it gave them a canopy, and then it gave their employees kind of an air-conditioned space, if you may, during that time as they were kind of setting up that type of testing. I liked it. It's great to hear the National Guard's coming in and doing that assistance with you too. I think it's a great way to make sure that we're keeping people tested and safe. So, thanks, Jamie. Oh.
Kevin, it looks like, and I don't know if this is Gene that's on at Savoy, or if there's somebody else that's there, but I think Savoy is part of a larger health system as well. So I'm curious, for our smaller hospitals that are part of a larger, maybe integrated health system, are you able to leverage some of the testing at the main hospital to get expedited, or also some of the waivers, like if there's residents and other medical students at the other hospital, that ability to have them come and help out at your hospital and not penalize some of the reimbursement rates. So if anybody's a part of a larger system, kind of what strategies you may be using. All right, Kevin, I'll hand it back to you and Jamie.
Sorry. Jamie, it's all you.
Okay, next slide, please. So this is the summation list for reopening service lines, and I wanted to touch on a few focused items. So I know in the beginning, many hospitals are struggling with reopening the OR with elective cases and implemented guidelines to decrease the virus spread and increase patient and staff safety. So stronger PPE guidelines, extended anesthesia procedures, additional pre-assessment questionnaires, and patient testing prior to surgery are just some of things that we've seen implemented. And as some hospitals face continuous surging or even resurgence in the United States, adequate availability of inpatient ICU beds post-surgery is essential to continuing elective cases. And lastly, we mentioned, or we would like to mention, that supply chain functionality and reliability continues to be at the forefront due to additional PPE needs, the limited national supplies, with both hospitals and clinic facilities having similar supply needs. It's important to be sure that those needed supplies are being stocked accordingly, and communication for any back orders, especially in procedural areas, are recognized and solutions are formed in a timely manner. And before we move on to labor productivity, are there any comments or questions that we can help answer?
I have a question, Jamie, and it'd be for the team. This is Kevin again. We think about some of the responses we had for the screeners and kind of the repurposing of folks. When we think about kind of the surgical service lines, did anybody continue doing surgery? I mean, and what I'm talking about is it's elective, right? You kept doing your critical surgeries in care, but did anybody continue doing some form of elective during the initial phases of when we were trying to decline exposures? Okay. So we've got one yes. Do you mind talking through, did you do any decision making at some level? This is the SMC regional medical team to everybody. Oh, it was never in the director. Okay. Yeah, I was on a call with the American College of Healthcare. Oh, go ahead.
Oh,
Yeah,
here we
please.
go. Sorry, we were trying to get the spokesperson closer to the speakerphone.
Good morning. This is Felicia. I'm the Chief Nursing Officer for the hospital system. At SMC, from what I remember and gather, we've had, it changes daily around here as far as guidelines and executive directives and everything. But, we were still able to be able to perform if we needed to. All we do there at this time is colonoscopies. We did not have anybody scheduled during that time. We also have our PPS hospital and, the same thing. We saw a drop-off with a lot of things for us during that time. For both hospitals, but I know that we were not, for the elective surgeries, the critical access hospitals and the rural hospitals in Arkansas, they were not a part of that advanced directive. We were, what's the word? I keep losing my train of thought. I'm working on, yes, exempt. But we just did not have anybody get scheduled at all down there.
Okay. One of the things that I would just add to that conversation is the pre-surgical testing or pre-admission testing that we might all consider. When we've gone through some of these coronaviruses in the past, it's changed our documents and our processes with our nurses to do that pre-screening after they've been determined from the physician's office. Keep that in mind. Those documents, and those are kind of in that checklist that Jamie was referencing, but always keep that in mind that are you going to be doing any further, pre-screening and testing? Are you going to have a 14-day, kind of need for them to come in to keep your team safe? What is your process and what are the guidelines you want to be using in that play? So what I was referencing earlier is the American College of Healthcare executives had an educational session a couple of weeks back, and one of the chief nurses that was speaking was from down in Louisiana, and they set up a process to where they made sure they kept some surgeries going elective, and they were in constant communication with their providers, but also their patients to assure them of their safe and well-being. And they set up an internal process of arrival and departure that was different than what their normal was. And the way they did that was to make, there were many processing steps. I won't want to go through that, but it was really just to keep their providers feeling comfortable, their staff feeling comfortable, as well as ultimately, that patient that's coming in to have a knee procedure or, a general surgery elective type of procedure. So those were the pieces that I wanted to see if anybody were still kind of in that consideration, because as you think about the timeline, I believe you're going to bounce back and forth over the next few months, and especially as we get back into the fall and potentially winter, if what the CDC and the experts are telling us, right? So we've got to keep our action plan kind of mobile, if you may, and really be able to let you kind of, I look at a comment there from supply chain. It looks like we're having difficulty locating PPE at a reasonable price. But it looks like now we're good. Is that true at Pennscott?
I didn't know, for the GPOs, Kevin, are you seeing, or do you know of any that are better or worse than others in terms of keeping up with hospital demands for things? you know, if you're one of the hospitals on here and you've got a GPO or some other type of arrangement that's been really problematic and found a way to get a workaround or talk to the right person, account rep, feel free to share that. But what are you seeing, Kevin and Jamie?
I can start, and Jamie, you can add if you want. So what we're seeing, Eric, when we're talking with the individual hospitals, is they're having to go outside their GPO. The GPOs were struggling with supplies also, so they were trying to get creative with local folks. So as a for example, here in Springfield, Missouri, some of the local companies started doing face masks, face shields, and so the hospitals partnered with their local manufacturers, you know, to get some supplies directly from communities. You know, you saw the federal government, you know, forced an automaker to get into the, or GE, excuse me, into, you know, making ventilators. But really those that really started to partner with their local and county and really state manufacturers to assist them with some of that PPE is really what we saw to be the most creative, Eric. I think the manufacturers have caught up because they've increased their production. If hospitals are going to be going through tremendous more of the PPE, and unfortunately there for a while the prices were going up. So hopefully we're starting to see the price to come back down, and we'll be able to adjust with that based on their ability to manufacture. So.
Specific to the ventilators, I'm curious to get an opinion from the nurses that are on the call today. Do you feel like some of that initial push in March and April that every patient needs to be, or majority of patients need to be on ventilator, was that a little aggressive? Are you seeing that in your local market? One of the things that I've heard is that it seems like more of the treatment is shifting to, you know, early thinners and not quite as much of the mechanical ventilation. So any nurse comments in terms of how you guys are really tackling the majority of your patients? No takers?
Hey, this is Gene. Can you guys hear me?
Yeah.
It's Gene at Savoy. Yeah, well, what we see more than ventilation now, we're seeing more of a pressure support in the BiPAP mask and that sort of stuff. It seems like we're tending to avoid intubation only as a last resort. And I say that because you asked for nurses. I am a CRNA, so also as the chief operating officer. So yeah, we seem to be not as aggressive with the intubations unless it's a last resort kind of thing.
Thank you.
We can move on, Jamie, if you're ready.
Yep. Next slide, please. So we're going to go into our monitoring labor productivity and realignment post-pandemic. Next slide, please. So as we look at labor productivity and during and post-COVID, it's important to establish baseline prior to the pandemic. This allows the facility to be able to see what is the norm and how they staff for these normal volumes. And once we understand that, we move into understanding the COVID-19 impact. So when we look at the timeline that COVID had impacted, which could be a bit different for some hospitals, especially because some communities were hit earlier rather than later. So we need to establish that timeline to see the fluctuations, especially if your organization did any furloughs, to see if department managers implemented flexing due to the lower volumes, or if there were overall reductions. And lastly, we need to develop the productivity standard going forward. And what that means is it takes into account the impact of COVID and the baseline. That productivity standard is worked hours per unit of service. In other words, how many hours did it take for our staff to complete 1 unit of service? And that unit of service really depends on the department. It could be cases, it could be procedures, or inpatient days. It's really defined by the functions of that department.
Jamie and Kevin, what are you seeing in terms of major changes from nursing ratios now with COVID patients? I would assume that it's a lot more intensive, and so our labor ratios may look off quite a bit, particularly during our crisis period here.
Kevin, did you want to take that first?
Well, I can. It actually, Eric, it's a good segue into kind of the next couple of slides. So if we want to move to the next slide, we'll give you some real live examples. And so let me orient you real quickly to the slide. And so what we find when we get, we're working with kind of that smaller and mid-sized hospital, most have some form of understanding around, that worked hour per unit of service and trying to get an understanding of what my staffing is. Eric, you brought up staffing ratios. We'll touch on that just briefly here in the next slide. But here's an idea that's, when Jamie was talking about what is the baseline. So the green that you see here, this is 2 labs. And the baseline, we took 12 months we have 12 months of data, and it's the procedures that they're doing within that lab. And it kind of gives you the volume for that annual basis. We look and really align the productive hours and paid hours. Those paid hours will give you the total FTEs all the way to the right. So in this particular example, you'll see that they were performing their total productive hours per unit of service in that top line, that first green lab at 0.260. There are benchmarks out there that we use when we're working with different hospitals just to kind of give them an idea of where it is a range that would be comfortable with you. And we have those for multiple size hospitals, multiple regions. And we usually will talk about that variance range. But where I want to focus your attention here in the lab, what's happening here in the lab, in the baseline to pre-COVID to really kind of that COVID impact. So you look at the dates that are in there. So the yellow line is 7 pay periods prior to COVID, and the orange line is really kind of in the middle of COVID and what's going on. In this particular lab, if you go to the total paid FTEs, there was really no adjustment to the people that were doing the activity. And then you would want to come back and look at the volumes. And if you were to annualize out those volumes, they really had a decline in the volumes. And so that really affects kind of how their production would go. So the COVID hit them that they didn't flex staff based on volume. They kept things open. And so their productive standard went up, and so did their range of variance based on that. And so the next one down is the emergency department. And we wanted to show, an area that, we're going to keep it open. We're going to staff it. And in this particular example from this hospital, again, you've got the green area of baseline of 41.7 FTEs. You look at during COVID, they had 35 FTEs. They were making some adjustments, but they weren't flexing to a large degree. So their variance range still stayed there. And you'll see that their productive hours per unit of service really kind of went up and spiked. Well, that's based on their volumes. And so I believe most hospitals saw a decline in their ER visits just based on people, delaying their care or trying to use the virtual platform to take care of something that they may normally go to the emergency department and seeing that. So Eric, in an emergency department, what we're seeing is the acuity of patients is going up. We're not seeing, if you're going into the ESIs, how you're going to do your triage with those patients. We're not seeing those lower acuity ESIs coming into the emergency department. So it seems they're either going to a virtual platform, or they're going back to an urgent care, or they're actually doing something with their primary care, or unfortunately, they're delaying getting care. And so then they come in 2, 3, 4 months later with a higher acuity. So yeah, we're seeing that higher acuity. And so the nursing staff are really having to spend more time with each patient based on that acuity being higher. Let's move to an area, go to the next slide. This is just an interesting, and some of you may or may not have behavioral health in and around your hospitals or your systems. But this is, even now greater than probably it was, the past 3 years. Behavioral health is definitely an expanding area that we need to be considering taking care of each other and delivering this care. In this behavioral health, this is a Jerry Psych, and so they're doing 55 and older, just to give you kind of an orientation of where they're at. But you can see during this time, they actually saw, if you were to annualize out that volume, that is actually a slight increase, but they had adjusted their staffing down during this time, and so their performance was better, and they were using less people. So they were able to take some of those nurses that may have been coming in, and they actually were able to reallocate them to areas of importance and that they needed someplace else. And so it's changing the staffing ratio, Eric, for what they were needing and usually doing. So their matrix is changing. So they're delivering a different model of care today than they were 6 months ago. And that their manager and their chief nurse really worked through this based on the resources of nurses that they have in that area.
Well, as I think about kind of the last two presentations we've had, about the PPP and the funds that have come in to help hospitals during these difficult times, that, this probably isn't the #1 focus on our staffing, since we may have had a cash infusion come in. But as we start to recast and move out of this is really where we need to understand where we were before, what it looks like today, and how should things be in 2021. So appreciate you, Kevin and Jamie. We've just got 2 minutes left. And so the last few slides are really about the waivers and the quality. Don't have time to go through, but there's some slides for you to look at. The biggest thing we want to make sure that folks know is that interim final rule that came out from Medicare in March and then was updated again on May the 8th does allow some opportunities, as you'll see on the next slide, for your organization to help with issues like access and on some of the testing. Now there's other folks that can do the supervision of those tests, can order them, gives flexibilities on where those tests can be done and still paid for. There's some new codes that are out there. There's a HCPCS code, C9803, that's specific to COVID testing. So as you adapt and as you recast, there are opportunities to make it easier for providers to do this work and to pay you for doing it. And so, as we're kind of running out of time here, what I would say is, if you've got specific questions on new ways to do things at your organization, and will it be paid for, and how much is Medicare going to reimburse for those things, if this is going to be the new normal, I'm happy to get you in touch with the folks on our team that are the nursing folks or the reimbursement specific, to kind of help you answer some of those detailed questions. So as you kind of look through the next few slides, there's some information on those. There's some information on your workforce and how that's augmented with PTs, surgery centers, your rural health clinics, specifically getting a waiver that they're not going to have to hit that 50% threshold that's been over there. And then your last slide, your patients over paperwork. So we really appreciate the opportunity talking with this team every Friday. I appreciate those who spoke up today. We really like hearing stories, boots on the ground, what's happening in your local market. It's good to hear about that. So I'm going to go ahead and turn it back over to Kate and Cinnaba to close us out of today's session.
Great. Thank you, Eric. And thank you everyone for joining us today. Thanks for our speakers for being here too. Just a reminder that next Friday, the same time, we'll be doing part 4 with BKD and the Delta program, and that session will focus on revenue cycle strategies. So we hope everybody can join us next week, same time. Thank you, and have a good rest of your Friday.
Happy weekend.
Thank you for having us.
Yeah, thanks.